So he's got the career and the credit score, but can he conceive? I've asked you this before. Well, Father's Day is around the corner and it is Men's Health Month, right? So we're going to get into it tonight. Yes, we are. It's going to get saucy. It's going to get a little juicy because tonight we're going to be joined by renowned fertility specialist, Dr. Stephanie Thompson. And, so before you stay, you're going to soak this all up for yourself. I want you to stop for a minute and share this so that the women and the men in your family and your networks are brought up to speed, right? So they have all the information. So let's start by welcoming you to Detox Living, where we bring you truths, tips, and testimonials to power your toxic-free living. That's right. I'm your host, Coach Gessie. I'm a fibroid survivor turned health activist and founder of the DETOXnow.com, a holistic health provider of education and supplements that help combat the nutrition and health disparities that lead to obesity, chronic disease, reproductive health issues such as fibroids, infertility, and more, and lead to lower life expectancy rates. So join me in welcoming Dr. Stephanie Thompson. I am going to bring her on. Again, don't hoard all this information for yourself. Here she is. I'm very excited.
Hi.
Hey, glasses. Yes, ma'am.
Happy
Hump
Day.
Hi. How are you doing today?
I'm good. Very excited to be here tonight.
Me too. Can you hear me okay?
I can hear you. Can you hear me?
Excellent. So, it's Father's Day is around the corner. It's National Men's Health Month, right? And something that we don't often talk about, it's also National Infertility Awareness Month, right?
Yep.
We talk about Infertility Awareness Week. There's this whole hoopla in April, right? But we got a whole month dedicated to infertility.
As much awareness as we can bring is great.
We can't stop having these conversations.
Absolutely.
So I figured the perfect intersection of men's health, Infertility Awareness Month, and of course celebrating fathers is a conversation around male fertility, right? Male fertility and male infertility.
Absolutely.
And, quite frankly, we have been the face of infertility as women for so long, but he could be the missing piece to our fertility puzzle, right?
It's very likely that he's the missing piece to our fertility puzzle.
Wait, hold on to that.
Extremely likely.
Get into it.
Yeah.
So let's start off with sharing who you are and how did you become Dr. Stephanie?
Okay.
I want to make sure they first of all know who you are because they need to follow you and make sure you're part of their tribe now. So how did you become Dr. Stephanie Thompson?
So I'm Dr. Stephanie Thompson. I'm a board certified OBGYN and reproductive endocrinology and infertility specialist.
Oh.
So after the medical school journey, I did an OBGYN residency and then a fellowship specifically in infertility, which took another 3 years and involved research, learning about endocrine disorders. And now I solely practice infertility medicine as well as.
So you have the inside perspective on the reproductive health portion as well as specifically fertility. But what sparked, how did you come to become that? Like what sparked that in your life?
Yeah, I always wanted to be a doctor. My father's an obstetrician and gynecologist. And, he is in North Carolina. But I said, I didn't want to do exactly what he did just because I don't want to do the exact same thing. But I happen to love GYN. And it's such a great field. Overall, you have such an opportunity to make a difference in women's life and in women, especially with minority women too, we're always underserved. But when I was training in OBGYN, I did a rotation in REI infertility. And the science and technology behind it just blew me away. And I think it allows you also sort of a different connection with patients, a little bit different than being on the happy pregnancy delivery side, but able to make connections with women and men who are struggling with trying to get. And, in the 15 years I've been in this field, the technology is even better, and we are so much more able to help people. And all the things that we can do are really cool with both female factor and male factor infertility.
Oh, I love it. I love it.
Yeah.
So we've got generational Black excellence. Hello. Okay.
Maybe we'll have a third generation. That would be great.
Third generation.
Your son too.
Your son would be. So you know, it's interesting.
You know,
it's interesting because when
that's the thing too when we just talk about medicine, and you know, especially how we are underserved in the minority community. I had a father who was a doctor, so I never grew up not knowing that that was possible.
Right.
And even as a shock and realizing that, you know, only 2% of physicians are Black.
Right.
Most people have never met a Black physician.
That's right.
Most people in the country, if you're not in a highly populated area.
Right.
So, you know, showing our faces nationwide like this on IG, and especially in fields that are pretty rare to see a Black person, there are about 50 of us who are board certified in the country. So
that's right. Did y'all hear that?
More of us?
50. She said there are 50 Black. You said REI, that's reproductive endocrinology. Let's give them the terminology.
Yeah. Reproductive endocrinology and infertility. So REI. Right. So it's a subspecialty of OBGYN.
Subspecialty. So 50. That is insane, right? So first of all, shout out to you for making it through that whole journey, because I'm sure there were a lot of roadblocks on the way. But I love that if you can see it, you can be it, right? Every physician that I have this conversation with, and there are a lot, there's always you know what, I always wanted to be a doctor. That seemed to be the thread. And that it was connected to, you know what, it's something that sparked me young. And for you to have that legacy.
Yep, the legacy of it, an experience you had, either you were sick or a family member was sick, and you wanted to be able to make a difference. You enjoyed communicating with people, helping with people. You know, I think medicine is truly a calling, that because it's a lot of work. You know, it's not easy, and the journey there is not easy. But it is a calling, and you know, if you can get there and you want to get there, you can do it for sure.
I love that. So my first question for you, it says, Black women have nearly a 3% higher rate, and let's check that, of infertility than their white counterparts. What do you feel plays a part in that difference in what you see?
I think, first of all, the most important factor when it comes to fertility is age, no matter what, you know. So our biology and the biology of other women is not different, right? So, you know, there's nothing about Black women intrinsically that's going to make us more, or
not because of race,
or more fertile,
right?
But I think Black women present to infertility specialists and even to their OBGYNs later on, you know, and I think that as we're collecting data, now we're starting to see that we do have higher rates, but that's probably because we're presenting later. And when we present later with fibroids, endometriosis, older age, it's going to be much more difficult for us to get pregnant, even with fertility treatment. I also think that, you know, those diseases are just more advanced because we're not traditionally taught in the medical profession about certain things, such as endometriosis, that may affect Black women. And, you know, we've talked about Black women are supposedly have a quote unquote higher pain tolerance according to traditional thinking, which is not true at all. But, you know, there was a study that looked at medical students in the 2000s, I think it was like 2006, that showed that 50% of medical students thought that Black women had a higher pain tolerance. So
can we stop right there for a second? Like, let that, she is a physician and she is owning, because we share that data all the time, right? And many people may think, oh, you're biased. First of all, I'm not biased against the medical field at all. In fact, we need each other. We need to, you know, marry, obviously, traditional medicine and holistic practices to have truly holistic, integrative health. That's my belief, period, right? And I want to take advantage of every, you know, innovation that allows me to have the health, the vision I have for my health, right? And I want to use everything I can to have the benefit of that. But what she just said is critical, that it is a study that was in the 2000s, around 2006. So we're talking about in the current, right, decade, right?
Yeah.
In the 2000s, right? That,
yep.
Not decade, because we're in the 20s. In the past 2 decades.
But in modern medical teaching.
In modern medical, let's just put it there.
Exactly. Believe that
50%. 50% said that we have a higher threshold.
Perpetuated from slavery times, where there was an excuse to operate on Black women without anesthesia and slave women without anesthesia, because thinking again that we were, had higher pain tolerance and, were more adept to be in the field. Similar to the concepts of why Black people were supposedly, the ones chosen for slavery to a certain extent, right? So
subhuman, right? The whole idea also subhuman.
Yes. So that has perpetuated itself. So we just have to reteach medical training, and we need allies within the system, because it's going to take many, many years before we get enough brown doctors, to serve everybody. But those people who are working with us really have to understand the historical perspective, and that allows us to be more sensitive and provide better care all around.
What's that like for you in a world where you are part of the 2%, right? And in infertility, I would imagine that number is less, right?
Yeah,
it's like like 50 out of all the REI doctors, REI physicians in the country, just even going in the country.
Very.
You're talking about 0.00 whatever, right? So what is that? When people have that perspective and you see the medical bias present, right? How do you how do you call that out in a room? How do you handle that?
Yeah, I think that we have to talk about listening to patients and their complaints and just sitting down with them. And I think being culturally sensitive to things that, for example, the stigma around infertility, right? For both Black men and Black women, and not wanting to bring that up to your physician. So, most women are going to go through their OBGYN first before they get to me. Well, we should talk about asking those questions. Do you want to become pregnant? Especially because there's a stigma that we're hyper fertile, which is not true. So as students and as residents and our primary care doctors, our OBGYNs, our urologists, everyone needs to be trained to ask those questions that might be what you think about that population, and listen to the answers to. And
that's sort of like, if I hear you, you're saying start to embed with the understanding that there are obstacles to when they actually get that care because of all of these biased perspectives.
Yeah. Here's I'm sorry. With fibroids, I see so many women who are offered procedures that are inappropriate for women who are trying to become pregnant, because nobody ever asks them the question. And then just
ding.
Yeah, but circle it back to the males, okay? The worst thing you can do for your fertility as a man is to take testosterone. And I see so many men who have been given testosterone, which can make you what's called azoospermic and not have any sperm, because no one asked a question. And they say, I'm with my partner, we're trying to get pregnant. So we have to really broaden our perspectives as healthcare professionals to ask comprehensive questions of our patients.
So that leads actually to the next question, which is perfect transition. What are the most important factors to consider when discussing fertility in men?
I think lifestyle is huge. That's probably one. Men, fortunately, don't have the same age constrictions, I should say, as women do, right? Men can conceive throughout their lifetime, and they don't become more subfertile until after the age of 50. But even well into their 70s and 80s, as we know, men can conceive. As we know, right? So, Al Pacino just had a baby at 80-something. Because men sperm every 3 months. That's the life cycle of sperm, as opposed to women who
sperm every 3 months.
Sperm every 3 months. Yep. So as opposed to women, we are born with all of our eggs. So when we get into menopause,
lifetime of eggs.
That's it, right? There's nothing we can do. We can't regenerate.
And how many
eggs.
weeks of pregnancy? Because it's really in utero we develop.
In
those
utero,
eggs.
we have in utero, about 20 weeks, we have 2 to 3 million eggs. By the time you hit puberty, you're down to the hundreds of thousands.
Wow!
And then
by the time you hit puberty,
you're down to the hundreds of thousands. So every cycle that you ovulate, you lose eggs. Every cycle. So, women are at a disadvantage with that. Men don't have those constraints. So the things that are really going to impact men are more lifestyle factors. Weight, we have an obesity epidemic going on. The environment is huge. Smoking is also the that you can do for your sperm.
About that. So weight, obesity. Let's break down. So let's first list them and then break them down.
Okay.
So obesity, you said
environmental factors. And then what was the last one that I just said? Obesity, environmental factors, and
did you say diet or toxic?
Smoking. Smoking. Excess alcohol consumption, not moderate, but excess alcohol consumption. If you have a problem with alcoholism, that could affect your sperm as well too. So when it comes
and what about, I've heard about weed. I've heard about smoking weed.
Weed is tough because we don't have as much data on it as we do with nicotine. I would say, look, if you're trying to get pregnant, then you should just be as healthy as possible and cut down on it as much as you can. We know that nicotine actually builds up on the sperm itself. It's called the flagellated ends, the cilia of the sperm. So it decreases sperm motility. The same thing with women who smoke, that nicotine gets onto the fallopian tubes and decreases the motility of the fallopian tube. So you see increases in pregnancy and not getting pregnant at all. But with men, smoking really can affect their sperm motility, which is important because then the sperm can't get to the egg. So when we talk about obesity, and that also goes into some of the lifestyle factors in the sense that the sperm,
nutrition,
very, very, very temperature sensitive. So the scrotum, if there's excess weight, there's also issues with hormone production. So we see that sperm production is decreased. The sperm morphology, which is the percentage of normally shaped sperm, also decreases, and the motility decreases.
When you have when you have an overheated scrotum sac because of excess weight.
Excess weight, right? And also things like if you're a cyclist, sorry guys, if you do a lot of Peloton and cycling, it's something you have to be careful with. Also, it is real, the saunas, hot tubs, spending a lot of time in those places.
Stay out that jacuzzi if you're trying to get them swimmers.
Yeah, not the right time. I know people like to make a baby, but not quite the right place.
Not the right environment. So when you so you spoke about obesity, environmental factors. Are you talking about saunas and jacuzzis?
About toxins, and actually, there were some recent studies looking at global warming as well too, and decreasing sperm counts worldwide. I think that also has to do with alteration of hormones, elevated body temperatures, that sort of thing. So there are also microplastics, toxins like BPA, which are now out of our plastic, right?
That's why I have a stainless steel thermos.
Yes. Chemicals in our environment, in our working environment, all of that can alter our.
That's a really good point, because one of the things we talk about with Black women is that, our lifestyle choices are everything from the food that we eat to, of course, the supplements that we take. And then also the products that we use in our daily, our personal care in our home, the plastics, all of those things actually have hormone disruptors. And we know that they lead to, reproductive damage, cancer, as well as carcinogens, as well as infertility, right? In terms of the hormone
issues.
It's
the same thing with men.
Same thing with men.
Yeah. So we have to be careful about our environment too. Those endocrine disruptors, I think, are really underestimated. We know not just from even I was mentioning global warming, but, realistically, there is a worldwide decline in sperm counts, no matter what. all of these factors.
Well, there is a rise in the toxicity of our products, right? The Environmental Work Group just did a study, and they found that 76%, and this is just on the female side, but it's the same. We're using the products at home. 76% of the products used and marketed to Black women actually had harmful ingredients leading to reproductive damage, cancer, and hormone disruption, right? So those products are typically speaking, you know, whether it's typically speaking, they're products we bring in the home and our partners are using.
Absolutely. Lotions, shampoos, I mean, cosmetics for women, you know, all of them do have disruptors, and you can find
they use hair gels. They use hair gels. They use deodorants. They use the shampoos and all the same, you know, home products as far as those are concerned. So that's a very good point.
The guys have to be careful as well too. And, you know, just to kind of share with everybody the anatomy of a sperm and why this stuff is important too, right? So the sperm has three parts. It has a head, tail, and midpiece. Most sperm are going to be abnormally shaped. They're very inefficient, right? That's why you need many.
Again, you said the head, the tail, and then the
midpiece.
You're sort of breaking in and out. I don't know if your signal is it a full signal?
Yeah, it looks good, and I'm on Wi-Fi.
It's coming in and out. I just want to make sure we don't lose what you just said.
Okay.
So head, tail, and the
midpiece.
And the midpiece
of the sperm.
Okay. And you know the shape, it's like one of those what do you call them? Those little Christmas ornaments.
It's like a head. We see it on this little squiggly line.
Right.
You know, guys remember that movie Look Who's Talking? And you see all the sperm.
All the sperm descending upon.
Yeah.
Right.
But that was one egg to very sperm. So a normal sperm
How many sperm?
To about 20 million sperm is normal.
Wow. To try to in an ejaculate. 20 million sperm.
20 million sperm.
This feels like this imbalance. This feels like an imbalance, God. Why they got 20 million?
Because they need it. They're not efficient. Okay. So is 50% has to be motile of that, right? So now we get down to about 10 million. Most of the sperm are actually going to be dead or immotile. And then also the morphology, you know, the majority of the sperm are going to be abnormally shaped. For fertility purposes, over 4% morphology or the shapes of the sperm is actually considered normal. So when you go for analysis and, you know, the doctor tells you that 4% of the sperm are normally shaped, it's okay for fertility purposes. We're never going to see 98% of the sperm being normally shaped.
What are high numbers that you've seen in terms of like, wow, the morphology of the sperm?
Sperm counts in the hundreds of millions. I've seen morphology.
That the morphology was normal. What are the high numbers that you've seen?
I mean, higher, 10 to 12% would be really high.
Okay.
Would be really high. Well, but my population is skewed too, right? Because most of the people I see are infertile.
Right. So they're usually dealing with it. So let's also define terms. So, because you were talking about the actual parts of the sperm, and we've heard terms like motility, the morphology, which you just brought up, which is the shape of the sperm. And then there's also there's another term that just escaped me. It's the sperm motility, the number of sperm, right?
The motility, the morphology, and then the concentration of sperm.
Sperm, right.
Other smaller factors. We look at the volume. We look at something like progression. So, you know, there are multiple factors that we look at on the semen analysis.
Okay.
So I'm here to say, guys, don't be scared of the semen analysis.
Don't be
scared.
Run to the semen analysis.
Run to
right?
It. Run to
Okay,
it.
so the next question was immediately. What would you say? So this is actually perfect. What would you say to a man supporting his wife on her journey to fertility treatment, but unsure of his own status? Run to the semen analysis.
You know, I would just encourage him to be an active participant.
Right.
Because women do have to go through more in terms of the workup. We do more blood work. We have to do more invasive testing. You know, we do ultrasounds frequently.
Right.
So for
all the time.
Yeah.
Right.
You know, the the semen analysis is not so bad. Usually you can produce it at home and then you drop it off in the laboratory. And then for most of the guys, it's just one blood draw, you know, as opposed to all the things that the women have to do. So just be a supportive partner.
Should it be automatic? Should it be automatic that there's a, you know, when a couple comes in your consultation, right? A couple comes and they're seeking fertility treatment. Is, you know, the consideration of both partners being factors always your approach?
For me, honestly, and in my practice, both people have to participate. You know, we need, because here's what could happen. I start the woman on a treatment and the guy doesn't have any sperm and I've done the wrong thing for her, right? So we have to know that he has available sperm.
Right.
And I also want guys to realize that because of all of our amazing technology, we actually don't need a lot of sperm. So don't worry too much if there is an issue with the semen analysis. Male factor infertility is probably actually one of the easier things for us to treat. And I think a lot of guys go into this being like, oh my God, what if my sperm count's really low? Then, you know, I'm not going to be able to get her pregnant even with fertility treatment. And it's just not true. So there's a wide range. Go ahead.
What are some of the, you know, treatments, and specifically, like, I know there's azoospermia. We had a client who, you know, her husband, he still had ejaculate, right? So you can still have very, you know, pleasurable sexual relations, but have no sperm in your ejaculate, right? And you wouldn't know it.
Ejaculation, you wouldn't know it.
Wouldn't know it unless you got tested.
And so, you know, one of the things I'll just say to that point is that the sperm is actually ejaculated, you know, in a gel, right? And then when it hits the vagina, then the pH of the vagina breaks it down. So and then all the sperm,
its own little egg.
It's its own little, it's its own little, you know, microcosm. So
bubble.
The volume, as long as it's within normal volume, and normal volume is 2 cc's, 2 milliliters, not a lot. But as long as the volume is normal, or I should say, even with normal volume, you can have no sperm, to your point. You can have what's called retrograde ejaculation. And we see that a lot with guys who may be on certain medications or maybe diabetic, and the sperm goes back.
So insulin can affect? Insulin
doesn't do it.
What is it? When you say we're diabetic, what's the connection?
Oh, just because of their endocrine disorder. With
the
diabetes.
Endocrinology,
not every
that also is connected to diabetes can affect that.
Yeah.
Okay.
To have retrograde ejaculation. And then there are things called like varicoceles, which are very common. They're a dilation of the veins in the scrotum, and it decreases sperm morphology and motility. So for guys who do have low sperm counts, a really low sperm morphology and motility, I do send you to the urologist to have an evaluation. So they'll do an ultrasound. They'll look for a varicocele. You know, it is in conjunction with what's going on with the woman and what you would decide on the treatment option. And then for guys with azoospermia, it really depends on what the reason is for azoospermia.
Okay.
I know it doesn't sound good, but you can actually go into the testes and take a biopsy and try and find sperm as well, too. Yeah. And when
I've learned of cases where one of our clients, they just they went into the store, he had azoospermia, and there was an absence of the vas deferens. So it was there in the sac.
Right.
It just wasn't getting, so it was a structural deformity, right?
Right. CBABD. So it's congenital bilateral absence of the vas deferens. And you see that with cystic fibrosis carriers. So,
and many are carriers. Don't even know they're cystic fibrosis carriers. They may not be dealing with it where the condition.
Something. You all can be cystic fibrosis carriers. Okay. We don't do ethnicity-based screening anymore. That is old. We used to screen Black people for sickle cell and thalassemia, and we screen white people for cystic fibrosis. Everyone is screened for everything at this point in time. Okay. Because, you know, we all are mixed up. I have a Ashkenazi Jewish thing that I'm a carrier for, right? So we do expanded carrier screening on all of our patients too. So just because you're of color does not mean you cannot be a cystic fibrosis carrier.
There you go. And because you don't know because it may not be manifesting in your body, you're a carrier.
That's
you don't know how it could be referred. And because, again, if you have no problem with coming, right? You have great relations. You may be thinking, I got sperm, but it's not coming through.
Right.
Right.
The other thing I hear too is, well, I have a child, so there's no way sperm counts.
Break that. Bust that myth. Let's go.
Right. And with guys, again, we talked about lifestyle factors. Okay. And how sperm is made every 3 months. Things can change very quickly. So you could have had perfect sperm 5 years ago, or you could have had one lucky sperm and now extremely low counts. We see it all the time. Also want to tell you guys who are bodybuilders and you're taking steroids. Steroids and testosterone. Okay. They can also lead to azoospermia, and they can also be irreversible.
So how does that lead? How do the steroids lead to azoospermia?
Yeah. So what happens is it's all down-regulating testosterone, and it's tricking your body,
tricking your body.
Right. Right. So any androgens that you take will down-regulate testosterone.
Yep.
So no excess steroids, no testosterone.
So we talked about azoospermia, and then you mentioned another one. It broke up a little bit. What was the other condition that can be a fertility factor?
Was it the varicocele?
With the
dilation.
Varicocele.
Oh, the varicocele. And those can be repaired.
So talk about that. Break that down a little bit more.
So it's a dilation of the veins of the scrotum. So basically, instead of being, a normal size vein, the vein is expanded. And so you get lower motility of the sperm.
Why is it lower motility if the vein is opened up more?
So it has to do with blood flow. So the sperm is not,
slows down the blood flow because it's too big of a...
allowing the sperm to develop properly because it's not getting the proper blood flow. So you get issues with fertility and issues with morphology with the sperm. They can be repaired, but we usually don't repair them and move to fertility treatment if the woman is older. If the woman is 25, you can try and repair them. But the reason that we don't repair them that often is because it can take about 6 months to see an improvement. And they often make...
How does it get repaired? How can it be repaired?
So the urologist repairs it. I don't do varicocele repairs.
Okay.
But what they'll do, they usually, I believe they'd go in and staple the vein.
Okay, so it's a treatment. It's not a medication. It's a treatment.
Right. It's a surgical treatment. For medication.
And every time you hear this, men are like, treatment on my not my nuts. That's how they say it. Yeah. Listen, we get this stuff all the time.
We do it all the time. So how do we get you guys to help us?
Your partners. You could be full partners with us on the journey.
And I think you also need to find a doctor you're comfortable with.
Absolutely.
You have to be in an environment that you're comfortable with. I think it's good. One of the things a silver lining of COVID was the advent of telemedicine. So, it's a lot easier for the guys to join the conversation now. I'll have a woman in the office and I'll say, give him a call, or I'm happy to talk to him, and just making sure that both partners are involved. But to your point, to go forward with fertility treatment, we do need the guy to be worked up. We need you guys.
Absolutely. So there are a couple of questions that came in. One, I want to make sure to cover it, was if you are trying to get pregnant, and it says, so women getting in sauna and jacuzzi wanting to get pregnant, will that affect it? And I heard, yes, it will affect it, right? It's very possible.
If you consistently, if you get in one time on vacation, it's not going to kill your sperm. But if you are somebody who's consistently using a sauna or jacuzzi, then it does have the potential to lower sperm counts as well, especially though the morphology. It's going to affect the shape of the sperm more than anything else.
Does it have any effect on the women's fertility?
On the women's fertility, not as much. For women, we really don't want you in the hot tubs and saunas when you're early pregnant. Okay, just because raising your body temperature to too high of a temperature, over 104 degrees, consistently can lead to birth defects. So for a woman, it's more important after you're pregnant.
Okay. Yeah. And then the other question I saw here, that's great information, was, does insurance cover this? How do you get more information on costs? So Absolutely. That has changed over the number of years, right?
So much. So I'm in New Jersey, which is a mandated state. New York is also now a mandated state for fertility.
Hello. Coverage. So let's look at where you live. Let's check these things, and you determine where you're going to settle, where you're going to work, what companies are focused on your fertility. Yeah. You know, it's a serious issue, right?
It is.
You definitely don't want to go to Alabama.
No, we don't. Check your benefits. Talk to your HR department. That's your first step.
Absolutely.
In New Jersey, the majority of teachers we see, you know, anybody who works for the state, actually, you have really good coverage. But the first thing to do is just check your benefits with your employer. And if you work for a smaller company and fertility coverage is not part of your benefits, you should actually go to your HR and talk about it. I've had many patients be successful with that, just approaching them and saying, hey, look, I think this should be part of a competitive benefits package.
Yeah.
You offer fertility coverage. You know,
that's a very good point.
Yeah. Access to care is key, and you will be so surprised at how good the benefits are now.
So just rounding back, so how does a man find out he's infertile? He has to have a fertility workup.
He does. He has to give a sperm sample.
That's the only way to know if he's fertile or infertile. That's the only way. Right. Don't assume you're fertile.
Mm-hmm. So you can be what's called azoospermic and not have any sperm in the sample, but it doesn't mean you don't have sperm within the testes.
Right.
Then there's something called oligospermia, which is low sperm count, so under that 20 million. And then there are normal sperm counts. And then again, we can address the shapes of the sperm as well as the motility of the sperm too.
Okay, so motility, the shape, the volume, the concentration, right? And then you said?
No, I just said that those are the most important factors.
Okay, awesome. So what are the chances that it's completely the man's issue and not the woman?
Yeah, somewhere around 35%.
Y'all hear that?
Yeah.
35% of the time it is the man's issue only.
Over 50%, it's in conjunction, right?
Right. Over 50%.
Right. So
he's a participant.
He's a participant. But pure male factor is a third of infertility.
That's high. And you know what? How many women, I venture to say, how many women thought the fibroids were causing them infertility and went through myomectomy when they didn't need to? Yeah. Because really it was the sperm that was the issue. A lot. Yeah. Because they're sitting here thinking, oh.
You're the fibroid specialist. So I just want to comment on fibroids. Just because you have fibroids doesn't mean that you are infertile or going to be infertile.
That's correct.
You have them properly addressed and worked on.
Correct.
But if you are struggling with trying to get pregnant, you're exactly right. You have to have the full workup. Our males must be worked up because, you know, all of the things that we go through, we can maybe spare ourselves too. And you want that for your
God. How many women how about this? How many women actually, because of the myomectomies they had now scar tissue that created fertility factors, right? Infertility now factors, and really it was always the male's
very possible. I will say that most myomectomies will not cause scar tissue. They really shouldn't if done well. They should not.
You mean scarring on like the fallopian tube, but there's going to be scar tissue because any healing requires scar tissue. But you're saying scarring that causes infertility factors.
Bad enough to cause infertility. Bad enough to cause infertility. It's pretty rare you see that, but it's very possible, and that's again why you have to investigate and do the right. thing.
There are also plenty of cases, at least I've talked to a lot of women who, you know, who have dealt with, because a lot of women don't realize that, you know, after some people they create their scar tissue, it grows. Like my doctor's like, oh my God, the first time I got cut, the second time but I realized that, oh my God, now 20 years later, right? I realized that there are things that they don't teach you, lifestyle things that cause your body to be more inflammatory, to have more inflammatory responses. 100%.
And that can be a fact. I personally have protocols I use, you know, that are anti-inflammatory. And I think it makes a huge difference in the right patient too.
Huge.
You know, it really does. And that's why antioxidants, I'm a huge fan of coenzyme Q10 and other antioxidants, incorporating those foods into your life.
Absolutely.
Really, for both men and women too. Because for men, it's called DNA fragmentation of the sperm. And antioxidants can help with that, right? Where you get breakages within the...
You broke up a little bit. You just said for men, because I want to make sure they heard that.
Yes. So men also can get something called DNA fragmentation in the sperm, which is something that antioxidants can help to prevent. But it's where you can get breakage within the DNA, and that can affect your fertility too.
And what can lead to that?
So for the DNA fragmentation, poor oxidation of the sperm.
There you go.
So it's all about aging.
So that's all lifestyle impact, right?
Exactly.
That is through nutrition, through supplementation, through proper sleep, right? Again, I love your whole integrative approach, because there's so many physicians out there that are like, oh no, that has nothing to do with it. I'm like, what planet are you living on?
You know, there's no one factor that makes or breaks pregnancy and fertility. You have to look at the whole picture. And some of these things too, I think, just help your overall wellness and cortisol reduction, stress reduction.
Absolutely.
And, you know, if I could quantify what stress does to fertility, I would be a billionaire. But you know, I can't.
Girl,
nobody. But
you would be a billionaire for real. Yeah.
But we know that whatever, as much as you can do to reduce it is good.
It's huge.
I'm a huge acupuncture. It increases blood flow to the ovaries and uterus. You know, these things, they don't.
Acupuncture is great. Absolutely.
In conjunction.
And you got to find the right mix for you, the things that work for you.
Absolutely.
Why does the quality of sperm matter when it comes to actual conception?
Yeah. It has to fertilize the egg. So if it's not normally shaped, if it's not motile, it's not getting into that egg.
Motility means like the force with which it's, like if it just doesn't have enough.
Right. It has to get to the egg. So that's the motility. And the shape, it has to be normally shaped to fertilize an egg. It will not fertilize an egg if it's abnormally shaped. So if the sperm, you know, has two heads, it's not going to fertilize an egg. So that is what happens in conception. And that's one of the cool things about our technology and what we do in IVF, right? That we actually will look through a sperm sample and find a normally shaped nodal sperm, and we can put it directly into the egg to assist with fertilization. Because for a lot of
embryos, right?
Create embryos, yes. Because for a lot of couples, that's what's happening. You know, because the sperm quality is poor, it's not fertilizing the egg. So we have the ability in the laboratory to do that. That's why male factor, you know, and that's why I said I don't want you guys to be intimidated.
Yeah, it's fixed. It's not.
We can.
It's a hurdle. That's right. That can be helped, right? Like, and you're always creating more of it, so you got more chances.
Absolutely. Even with inseminations, you know, the amount of, and we can talk about abstinence too. This is a question I get a lot. You know, what is the amount of abstinence? So when you're giving a sperm sample, it's 2 to 7 days. So you would think that if you're abstinent for like 2 weeks, sperm's going to be great, but you get high concentration of sperm, but poor quality. So poor
good information.
Sperm. Okay. So when you're abstinence period is shorter, you may have a lower concentration, but you're going to have less dead sperm. So sometimes insemination for some guys will help too. And that's where we would take a sperm sample. We wash it. We get rid of all the dead sperm. We get the most motile sperm. And then we put it directly into the woman's uterus at the time of ovulation. That's a first line, also depending on what.
But most people go, well, definitely with later pregnancies, most people are going straight to IVF, right?
Most people are going straight to IVF, especially over the age of 38. It works really well. And we touched on this. I just want to make sure that everyone understands when we were talking about carrier screening and being a carrier of a disease. So there are two things that we can look for in embryos. And I'll just back up. You know, all of us most of us are maybe carriers of some disease in the population, right? But our child is not affected with it, and we're not affected with it unless our partner is also a carrier. So what we screen for are things called autosomal recessive disorders. So, you know, if I'm a carrier, my partner is a sickle cell carrier, my baby has a 25% chance of having sickle cell. We can look for that in embryo through IVF. The other thing that we look that's super important are abnormal chromosomes of the embryos. And that is looking for things like trisomy 21, Down syndrome, missing an extra chromosomes. But we look at the whole chromosome spectrum because that is the issue with age. So we talked about
with age, you have more abnormal chromosomes.
Because of the age of the egg. When the egg is fertilized, or if it even fertilizes, but when it's fertilized and it creates an embryo, it doesn't grow and divide properly because of the age of the egg, because of the ovarian age. So we get missing DNA and extra DNA, and that causes us to not get pregnant, you know, on our own, or if we look at it in the laboratory, it can cause a miscarriage.
Well, with the
cause a child
retrieval, can you, so I actually, you know, my baby is a IVF baby. Fifth cycle.
Wow.
And I got tested, cha-ching. It was more than 12 years ago, right? But it started in my IVF journey started in 2008. And I actually have autosomal dominant polycystic kidney disease.
Oh, wow.
So that was right. So we actually did something called pre-implantation genetic detection, which is the testing of the embryo for that disease, because up to 75% of people with that disease end up on dialysis.
Right.
And I just didn't want that for my child. I lost a lot of family members on my father's side due to that kidney disease.
You bring up a good point. Autosomal dominant disorders, you have a 50% of having.
And 50% of every single set of those embryos we lost because they were affected.
The family history, when you go and talk to your doctor, is super important because those things are identified more on a family history than an expanded carrier screen, because those are going to be affective disorders, but dominant disorders require a really good family history. Everyone who comes through CRM New Jersey with us does genetic counseling and does a full family history.
No, and the family history piece, sometimes, you know, I found out I had the kidney disease when I found out I had fibroids, because when they, you know, and I found I had fibroids because I was trying to find out why I wasn't conceiving. And they said, oh, you know, I went to a GYN for my pelvic exam, and she said, oh, you have fibroids. I was 30 years old. I was like, really? What does that mean? And started that whole journey. And when they went to do the sonogram, she sent me for imaging, they said, oh, did you know you have kidney disease? You have cysts all over your kidneys and your liver, right? And then I realized, wait a minute, there was a disease that I've heard them talk about in the family, but nobody ever said, hey, it's from your father's side. It's been carried on his father, his brothers, you know what I mean?
And you know,
so it's
quiet about family history as brown people. And we
and that's what I was going to say. And that goes back to the not talking about, especially on, you know, as Black and brown people, not talking about what's going on in our family history so that we can actually help the next generation, right? Like, hey, so, but the wonderful thing is, I always say IVF was a wonderful gift because my daughter never has to worry about passing that on to her children, right? It was one of the greatest blessings, you know, in that. So I appreciate, that opportunity.
Yeah.
Okay. So how can one, as a male, boost their fertility? I heard lifestyle factors. So we can do things like stop smoking. We can do things like, lose weight.
Alcohol consumption. We can lose weight. We can get regular exercise. And even with exercise, we don't have to go crazy and be orange cherry nuts.
Right.
You can just walk.
Right. I was just going to say walk.
Yep. Walk. It makes such a huge difference. And, it's not hard to do. But you have to be very intentional about it.
Right.
Especially sedentary job, because I know when I just sit at my desk and I don't get up, I get 1,500 steps for the day. My goal is 10,000. So you have to be very, very intentional about walking. Sleep is key.
Sleep is key.
Rhythms are very important. 7 to 9 hours is ideal for an adult.
I'm curious, how many people get 7 to 9 hours up in this chat? I'd love to see.
I know.
If you get 7 to 9 hours of sleep, let me see some hearts.
Like real sleep. No.
Like real sleep.
No,
I see somebody just wait. I don't see any hearts though.
Nope.
Y'all not getting any sleep. Like I said, we don't even realize the brain damage it costs not sleeping properly.
Yeah.
It's serious. Okay.
Take your CoQ10, take your multivitamins, even for guys. I love acupuncture, like I said before, for stress reduction overall. And, I think good communication with your partner about fertility and what they're going through and what your goals are is a good start too.
Absolutely. And, for us, we've helped, we have a little miracle baby wall, which, we've helped several families, whether it's through getting the right nutrition protocol, the right supplementation support, to help with their journey. Because the truth is that, you can do it. You are not alone. I remember going to the fertility specialist and not seeing Black and brown babies on the wall, being like the only Black mother in the waiting room, right? Because of what you talked about earlier in terms of access, right? Yeah. And, and knowing now, wait a minute, we have to be a part of the conversation. We do. And have tribes, communities that are saying, no, I love Ebony K. Williams announced her pregnancy today. And was so happy for you, Ebony K. Williams, right? Yeah. Judge Ebony, and all the things, who's been on her journey, but I love that story is being shared and all the stories, because it goes back to that. If I can see it, wait a minute, that's a reality for me.
Absolutely.
It's something that could be real for me. So
you can, we're here to help you. The outcomes, just don't wait too long.
Don't wait. Don't wait. How about egg freezing? We didn't talk about that because we're talking about male fertility. But I want, in this regard, right? Because many times I feel like, we as women, especially in this season, in this generation, a lot of women are very professionally focused and not focused on their fertility. And then they're waiting around to see what this relationship's going to be like. And the truth is that, part of what science allows us is freezing our fertility in time as early as possible so that we have more options later, right?
Yeah, and it works really well. I won't say that 10, 15 years ago that the success rates were what they are now, but they're really excellent. The younger you are when you freeze the eggs, the lower number of eggs you need and the better the outcome. But that doesn't mean that women in their later 30s or even early 40s can't freeze their eggs. You just have to have patience. And I think you have to understand all of the caveats and what that really means for you. But it absolutely can be done. And again, the technology works really well. And the reason that it does is because we now freeze eggs in the same way that we freeze embryos. We used to freeze called slow freezing. So it was like this really, really slow drop in temperature. And then when we would try and rewarm the eggs, they would form ice crystals and they just weren't good. They didn't.
But now the technology has improved, right?
So freeze them just like we freeze embryos. They're flash frozen in liquid nitrogen. It's called vitrification. They can essentially be like that forever.
Wow.
But from a maternal health, perspective, our age that we want you to use them by is age 50. There are some places, yeah, just because of the risk to being pregnant, as you get, right?
So someone brought up, it feels a little cost prohibitive. It's true, it is expensive, but something my colleague Calais Stewart, my dear friend and colleague Calais Stewart in this fertility work, she created something called the Parenthood Journey on Evite, where now you can throw yourself an egg shower and say, hey, all the people who you've been going to their baby showers and bridal showers, and they want to be able to support you on your fertility journey. And so throw yourself an egg shower, right? Let them support you to, and you can do an IVF shower. There's egg shower, there's IVF shower, there's surrogacy shower now, there's adoption shower. So wherever you are on your parenthood journey, you can enlist the community, the support of your community, by throwing yourself a shower. Yeah. Absolutely. How many people feel like sometimes your community feels like their hands are tied and they're just like, well, I'm just praying for you. Now they can do something. They can pray and do something else.
Absolutely. Yep.
Right?
Yeah. No, but I think egg freezing has modernized women's fertility in the same way that contraception did in the 70s. And I think we're going to get there. And of course, as we get better and better, the cost will come down and we'll see more universal coverage.
Right. Yeah. I agree with you. Okay. So
because again, competitive benefits package.
Right. We want to see it in the benefits packages now.
That's right.
Listen, we're also trying to protect IVF in this crazy world we're living in right now.
I know. Well,
crazy.
Vote.
Yes, vote. Very important. Last question. So let's discuss the stigma in men and men speaking on their health, especially their reproductive health. We've talked about it in terms of the fact that they don't, and of course the reality is connected to Black and brown people, and slavery and the things that we underwent. And to this day, I mean, I'm not gonna literally act like it's not present. Medical bias is still very, very present. It's seeped into the system.
It is. I think
how do you help men deal with the stigma?
Yeah, I mean, I think that one of the main issues is pride and the thing that, we have so much going on as Black people in general. It's just, there's something else. And I think we may play into that hyperfertility a little bit, right? With the guys. And that.
Yeah, my Johnson works,
We have no problem. Why? Probably that historical perspective as well, too.
It's true.
We were supposed to breed, quote unquote.
Absolutely.
So same thing as with Black women. Black men aren't supposed to be infertile.
Right.
And then guys, it's harder to get you to go to the doctor. Again, the general mistrust in the healthcare system. You're busy, you're tired, you're trying to be a provider, you're trying to be all these things. And, you're neglecting your own health. And it's women in our lives who push us. But if you're not necessarily on that pregnancy journey yet, it may not even be on your radar. Right. But trust me, it's a bad thing to go to LabCorp and get a semen analysis or whatever.
Have you ever seen a man who is not in a relationship where they're trying to conceive to just get a semen analysis to know his status?
A couple.
Wow. Yeah. I love that.
But a couple. And there's some at-home,
There's an at-home test. What is that like?
Yeah. I forget the name of it.
But you can just order it on Amazon?
Yeah, and then you send it in. I've heard it but it's a sperm or not in those situations. I think it doesn't give much of an accurate picture, but at least that you're producing sperm within an ejaculate sample, right? As opposed
to in the right direction.
Yeah, but most guys are going to be doing this in conjunction with a woman, but I've had guys who have just come to support their girlfriend, a friend who's egg freezing, and they say, hey, let me just check it out and see. It happens.
I think,
but we need to, it's okay for just the same way that we check our anti-Müllerian hormone level, or we go in and say, hey, you know, we want to know about our fertility.
We haven't talked about the AMH. Why don't we, because we were talking about male fertility, excuse me. But AMH, you know, FSH, the hormones, do males have to check those hormones as well? I mean, do they have those kind of hormones to check as well?
They do. Not AMH, because that's made from the, but testosterone is their estrogen.
Okay.
So usually I don't work up the guys. I send them to the urologist to do testosterone.
Got it.
But that would be your equivalent. But guys can also.
So when they do after you do the analysis, that doesn't really check the hormone piece. The urologist does that.
Urologist will do it. But guys can also be what's called hypothalamic. So you can have low testosterone, low luteinizing hormone. They also have, you know, FSH as well too. And if you have low testosterone, you can be very tired, fatigued, have low libido, you know, also have issues with sperm count. But don't let anybody give you testosterone. If you can leave with that, anything is that. There are things you can take to increase testosterone production that are not directly testosterone.
Not taking testosterone.
Right. Letrozole. There are other drugs that will increase testosterone and sperm production. But if you take testosterone directly, then you can have an issue with sperm production. Yeah.
Is there any male fertility factor that shows up in erectile dysfunction?
Sure. Low testosterone.
So that's the one, low testosterone. So that could be a telltale sign. So ED could be an indicator that there's low fertility.
Yes.
That's good to know.
And you know,
is there anything
to get checked out? Even if you're not get pregnant. But as part of your general health, you should be thinking about your fertility. Just like women.
Your general health.
General health. Regular health.
It is part of your, I think that's part of the reprogramming, right? That our reproductive health is an indicator of our overall health.
Overall, right? 100.
It's an indicator of that. And because of that, we want to know our status.
That's right.
Everything. In everything, right? So, Dr. Stephanie, thank you so much for joining us for this conversation. We got into it. 35% of the time, it's literally just the man. And that is a huge takeaway because there's so many people who don't even see that as a possibility, right? 50% of the time, it's both. So that alone should make you come out the door right away. I always say if you are red flags of infertility, one of the top ones is you're the only one getting tested, right?
Right.
Another one is if you may not even be, you know, in the relationship where you're thinking about children yet, but you've decided, you know what, this is a serious relationship. You may not even be ready to get married yet, but you've decided, you know, maybe you're doing a long engagement.
That's right.
You need to know.
You need to know. Be your best, healthiest self. This is part of it.
I always say the earlier you know, the better of a plan you can make, right?
Absolutely. Yeah, and the more intervention.
More intervention you can access.
But there's so much we can do when we know. So
knowing is half the battle. That sounded like
power.
Knowledge is power. Thank you so much, Dr. Stephanie. This is the first of many conversations. I love talking to you, and thank you so much for the work that you do. Follow Dr. Stephanie. She's tagged right here in the IG. She's Dr._SM Thompson. Do you have a website or anything you want to share with them?
You can find me at ccrmivf.com or irms.com, and I'm based in New Jersey.
Excellent. But do you do telehealth outside of the New Jersey area or just?
Nope.
See that?
I do.
Excellent. So you may need one of the 50 Black fertility specialists to consult on your case and maybe connect you to someone locally who she can help you find, right? Like these are things that we have to remember, that the people who are doing this and understand this, these are the people we need in our tribe, right? This is the village, right? And so add Dr. Stephanie to your village.
Thank you. Thank you so much.
All righty, you take care.
Okay, bye-bye.
Thank you so much for investing in your health today by listening and being with us, whether you are on the replay, catching us on YouTube, on all podcast platforms. I just have to say that, you know, men's health, it's healthy women plus healthy men equals healthy families in terms of how our health outcomes affect and they impact one another. Understand that healthy partners create a healthy family. All right. So please, if you are going through and, you know, you're just needing support, you're looking for support, we're here for you to connect you with whoever, the physician partners in our network, to helping you to assess, you know, maybe you're early on and you're not ready to have a child, but you want to make sure that you're taking care of your reproductive health early on. Hey, let's not wait until you have a crazy period. Sisters, let's not wait until you have issues with your hormonal balance. Brothers, or vitamin D deficiency or chronic inflammation or more. Please visit thedetoxnow.com, take our free quiz, book one of our free consultations or a private one with our nutritionist so we can partner with you to determine and develop the right plan for your health and healing. And if you are trying to conceive, we are so passionate about your helping you bring your vision to life and having your miracle baby. And know that you have support. You are not alone. All right. So thank you so much. And make sure to tune in and follow us for more.